of excited at that time, but close to the end, when I was giving him the feedback, the things he did right, the things he did wrong, he asked me the question, well, Dr. Hassan, how much do you think we should do all this instead of just ordering an echo? To be honest, I couldn't really give him a scientific answer to that question. I told him, it's always good to have a good physical exam skills. You might need it at one point or another. But I couldn't really answer his question in the right way when I think about it backwards. So that's kind of triggered me to go back and look into the literature to see, the maneuver that I have learned in my medical school. I was trained in Sudan, and we have to rely a lot on physical examination in my home country to make a diagnosis because we have limited resources. So we're thinking all these maneuvers I have learned, whether I really need to do any of these or not. So basically, I'm going to take it through the four milestones. We're going to talk about the data that we have regarding the decline in the physical examination skills, and I'm going to talk about why that's the case, and possible reasons that can explain this phenomenon. And then the important question is: do we really need to worry about that? Whether it's really a major thing that's happening in our daily practice or not? And then probably the last thing is just touch base about the evidence-based physical examination that we have currently. I don't know if any of you guys know this gentleman here. Probably not, but maybe more of us are familiar with this picture. Any idea? Yeah, exactly. So this is Mr. René Laennec. He's considered by many to be the kind of the father of the modern physical examination because of his invention of the stethoscope. Basically, this is the picture of depiction, maybe not the real case, but what led him to the invention is he had a young lady, obese lady, who he had to examine, and it was difficult for him technically to do the examination. So he invented that piece of wood, and he remembered from his childhood when they used to scratch an end of the wood and they hear it in the other end, they actually hear it better. So funny enough, actually, when he kind of published his invention, a lot of physicians, they were like very not really excited about that, and he got a lot of criticism. And it was mentioned that actually the founder of the American Heart Association at that time, he used to have his own handicraft and examine the patient directly, and they used to say, if you have ears, don't use a piece of wood. But apparently his invention went all the way until we have this fancy stuff now, the electronic stethoscope, basically, which can record a lot of the breath sound, and I think it's a very nice tool for teaching. So back to the milestones again. So let's talk about the data we have about how real the perception that the physical examination is really declining through the years. So this paper is actually published last year by the American Association of the American Medical College. They looked into the performance of the medical students who took the exam in 2011, only the U.S. medical students. And they looked into the technique and maneuver of their physical exam because we basically know it's not really a real patient, so there's no real science. So they only, the standardized patient, they just check how you do the maneuver. And they looked into the major 5 systems, and they compared the scores in the physical examination part to the history part. So this is what they found, actually. There's the mean score for the physical examination was much worse than the history. And not only that, it's the standard deviation also for the physical examination compared to history was wider, meaning there's probably more discrepancy between the scores of the different candidates in the physical examination. And they looked into which systems the candidate did poorly, and which goes along with the prior papers. It's actually the musculoskeletal and neurological systems, almost 50, the mean of 50 to about 80 in the history of these two systems. And again, the standard deviation, or the wide standard deviation, still applies here. So, it's one of the only one of the papers really that talked about this, but there's many others. And this one actually looked into the performance of not only the medical student but also the residents and the faculty, and that also showed some errors during the physical examination technique. And it's probably not a phenomenon only here in U.S. This last paper is published in New Zealand, and they're kind of noticed the same phenomenon. Okay, so if we go to the 90s, still that applies, the phenomenon of poor physical examination. And this is actually a very interesting paper they published in 1995 in the JAMA, and it looked at the how well the primary care doctors evaluated patients with specific physical signs related to HIV. So what they did is, they recruited primary medical doctors using the MA directory. From different 5 states, they randomly selected 134, and they presented the study for them as a CME course or research that they're gonna introduce them they're gonna examine 60 patients during the day, and 16 patients, during the day, and that they're gonna they have 20 minutes for each patient, and they take the history, they do the physical exam, and then at the end of the encounter, they just write down their findings, their physical findings on their differential diagnosis and the workup, kind of similar to the CS exam. So they specifically looked into 4 cases related to the physical examination. They had a patient with Kaposi sarcoma in the left ear and the right shoulder, and they trained the patient, the real patient, to kind of, among the complaint that they have, they actually kind of direct the physician to where they have the physical signs. So the patient with the Kaposi sarcoma, he had a complaint of resolving pain in the left ear and right shoulder. There's where his lesion are. I'm going to show you the picture of that lesion. And they had a patient with oral hairy leukoplakia, and that patient had a complaint of sore throat and a white spot in the mouth. I mean, it couldn't be more directed than this. And then the third patient is a patient with generalized lymphadenopathy. He had anterior, posterior, axillary, pre-auricular, post-auricular lymph nodes, and that patient gave a history of fatigue, fever, and arthralgias. And then they have another 2 cases of diastolic and systolic murmurs. So these are the lesions. These are the, I don't know if you can highlight it. This is a Kaposi sarcoma patient in the left ear, and this is the white spots of the oral hairy leukoplakia, characteristically at the side of the tongue rather than the top, and only involving the sides. And again, they were kind of directed to the side of where they should look at. But surprisingly, in the case of the Kaposi sarcoma, only 47% of the physicians were able to, not making the diagnosis, but only saying that actually they have seen a lesion in their ear. And, 25% actually got it right too. So it's not like there's some physicians who are able not only to recognize the lesion, but also to make the diagnosis because it's so characteristic as you saw in the picture. And then for the oral hairy leukoplakia, it's about the same, a little bit higher percentage of physicians that were actually not able, again, to mention that they saw any white spot in the mouth, despite being directed by the patient. And only 22% got it right. And even more surprising, the patient with vague symptoms, it looked like only 17% of the physicians, they actually examined the lymph node, and they were able to detect the lymphadenopathy. And of course, you can't make a diagnosis at this point, but at least they only 70% have been able to say, yeah, there's lymph node in this patient. So this is kind of surprising. So they look into subgroups in terms of the recruited physicians, specifically regarding what they report about their experience with HIV. So what they found is a patient who said, yeah, they feel more comfortable with HIV patient, they are the ones who picked the oral haloleukoplakia statistically significant than the others. And the other subgroup, they looked into, they divided the physicians depending on their experience or the year of graduation. And those who, probably have more experience, they were able to detect the murmur statistically significant than the others. Which actually goes with the finding in terms of the cardiovascular examination. They said, of course, the more experience you have, the more you're able to detect physical findings. All right, so the next is actually just, the last one was about PMDs, missing HIV infection in the 90s, but this phenomenon is actually goes all the way back to the 80s and to the 70s even. It looks like physicians, even at that time, they were not happy with the performance of their, medical resident or student doing the physical examination. So it's not something new, and it's nothing to blame the new millenniums for, but it's more pronounced now. So possible reasons, I think probably we all know some of these, but I'm going to go over some of what I think is probably because of that phenomenon. Probably lack of training in the medical schools and during the residency. And actually one of the studies showed that probably the skills actually stayed in the stage of medical students, and the physical examination skills, unfortunately, is not developed beyond that. Another problem would be the availability of the technical surrogates, so to speak. Basically, we all had easy access to the ultrasound, CT scans, MRIs, and it's just by a click in the Epic, and you get it done. So this also could be pushing the physicians away from relying on their physical examination. I mean, why should I rely on my physical exam when I can just look at the echo? And then the fear of medical litigation is always there, and probably some physicians feel more comfortable if they do more testing just to quote unquote be safe. And then pressure of time. I think this is probably a major one, especially in our daily practice. If you have to see 15, 20 patients a day, and you know that you have to go back and write your assessment and plan, and you want to write it in a way that gets you the most in terms of reimbursement and all this. So it's challenging to think about staying a little bit, couple of more minutes with your patient, doing more or better physical exam. And then one major thing, which is actually I was lacking in that last point, which is how much we know about the value of physical examination, how much we really think the data showing us the physical examination actually can work, and there is evidence based that's actually useful in many clinical situations. So probably sounds familiar to many of us. I don't know for which reason this physician picked to do the testing despite the fact that there's diagnosis in front of his eyes, or doing an x-ray in this patient. But it's something we all go through basically every day. All right. Do we need to worry? Is it really something that's maybe just a natural history? That's really that's the way it is, and it's probably okay. Or there might be an issue with that, even with the era of availability of testing. In other words, are we missing something here in our daily practice? Is patient physician satisfaction an element in all this? I mean, definitely all of us, we feel really bad if the nurse told you that, we still have the central line in. Do you want it out or not? And you realize that actually when you examine the patient, you haven't noted that actually the patient has a central line. And, and sometimes even worse if it comes to like missing a diagnosis, and you feel like probably I missed that during my exam. The other thing, which is probably maybe a little bit more important, is patient satisfaction. Is that a factor that really affects the perception of the patient that they have been well taken care of. And it's actually, for the bedside manner, there is conflicting data. Some research say, yeah, it does matter. A lot of patients say, I really like my doctor because they really examine me very well. And they said probably not. They're more excited about communication and other bedside skills. But I think it makes sense that the patient will feel more safe if they knew that their physicians examined them well. And I remember during my residency, actually, the preceptor one day he was kind of mad because he got a letter from one of the patients telling him that the patient came for like quote unquote full physical, the annual physical, and the patient left without him, without any of the resident or the examiner resident actually take any part of his clothes off. They didn't look at the feet. They didn't listen closely to his heart. They didn't really examine the belly, without the shirt off. And despite the fact that there's some data regarding the importance of the annual physical exam, but still, I think from patient perspective, it might make a difference. And then, of course, money is always there. There's a lot of initiatives by the AMA and other medical bodies that they're talking about the wasting of money in ordering unnecessary testing. And then, maybe more importantly, is the patient safety. You always have to think about the test that you're going to order for your patient. If you're going to order a CAT scan on your patient, and unless it's really a safe CAT scan like this one, probably you have to rethink about the side effects of the dye, the side effects that the patient might have a nodule in the chest that need to be pursued down the road. And as you all of you are aware of the consequences of biopsying like a benign lesion, especially here in the valley when we get the high prevalence of COXI patients. And then the last important point is really, are we missing diagnosis? That's really a question. If you don't do a quick physical exam and you rely mostly on the testing, is it really going to make a big deal? And the only research or the only paper I got that's really directly tackling that question, whether the physical examination done by an experienced physician will make a difference in the diagnosis and management of patient admitted to the inpatient. So this physician here, he examined 100 patients during a 1 month period in 2002. He examined all the patients admitted to his service. He's a hospital, a geriatrician, and board-certified internist. He examined all the patients admitted to his service after they have been examined and evaluated by the ED physician, the ED resident, and the admitting resident. And then he examined all these patients within 7 hours of admission. And basically, he examined the patient. He took a history, examined the patient. He's aware of the prior documentation by the other admitting medical staff. And then he documents his own findings and whether his findings agree or disagree on in which way he agree or disagree with the prior evaluation. So basically, they're trying to say that their staff is kind of good and their residents have very high scores in their examinations, and he has like 25-year experience. So it's not like their medical resident or the ED physicians are not that good. So he looked specifically at what he called a pivotal physical finding, and the definition of that in the paper was, it should be a physical sign. It's something that you detect by inspection, palpation, percussion, or auscultation. And then it prompted a revision of the initial diagnosis made by the admitting staff, meaning probably you guys missed the point. This is not what's going on with this patient. And then the other thing is it should actually lead to a change in the management, meaning without this physical finding, the management wouldn't have changed, but because of his physical examination, there's a change in the management. And there's three senior physicians, three physicians that looked into what he called a pivotal finding and kind of reevaluate whether this is really an important physical exam finding or not. So they divided these signs into discoverable pivotal signs, which are physical findings that actually can be detected by imaging. Splenomegaly, for example, if someone has abdominal pain, you can still be able, most likely they're going to get an ultrasound or CT scan of the belly, and they're going to see the largest spleen. So this is discoverable. And then there's a validated pivotal sign, which is what he really wants to get that. Is basically the physical finding leads to a consultation to a new service. And that consultation, actually, they did change the management. And then he really wanted his physical finding to be classified as class 1 pivotal findings, which are the physical findings that are not discoverable by the relevant investigations, and they are validated at the same time, and they led to new consultation. Anything else is class 2, basically. So among the 100 patients, he was able to find 7 cases. 7 cases, his physical examination after 3 physicians examined the patients. He's actually changed the management, changed the diagnosis, and lead to a consultation to other services and changing the plan. And I'm sorry, it's a little bit crowded, but I'm not going to go over these cases. But I really encourage you, especially as a resident, to go over this. It's kind of interesting and in many ways kind of funny. But I'm just going to give a quick example. So the first one is a patient admitted with sepsis, upper extremity sepsis, cellulitis, and probably staph, and they started with antibiotics. But during his physical examination, he actually found that the patient had like a thickened, tender vein in the antecubital fossa, and that led him to the diagnosis of thrombophlebitis, and he consulted vascular surgery, and they did thrombophlebitis on that patient. Whether the antibiotic is going to work alone or not, this is another discussion, but at least this meets his definition of pivotal findings. And then the other case is a patient admitted with delirium. Of course, it's hard to, sometimes it's not easy to make the cause of delirium at the initial evaluation. But basically the patient was, he started on Haldol and undergoing imaging, and basically during his examination, he found the patient having a slow response, and he actually have a good attention span. And by definition, as we all know, the higher function that's most importantly involved in delirium is attention. And what I usually do to examine that, you can ask your patient to subtract 7 out of 100, but because I'm not that good in math, I usually ask the patient to just name the months backwards. It's a very simple, quick bedside to test for attention. So he did that, and he thinks probably the patient is not really delirious, he's actually depressed. And he called psych to evaluate the patient. They agreed with his assessment. The patient was started on antidepressant and psychological treatment too. The third one is a common case that we see all the day in our hospital here. Patient admitted with acute coronary syndrome, started on heparin, aspirin, Plavix, and then during his physical examination, he actually discovered that there is some neurofinding in the upper extremities, and he suspected cervical stenosis, and he was damn wrong. They did the imaging, and they found cervical stenosis. They called neurosurgery, and the patient ended having surgery in his neck rather than heparin. So, I mean, it's really, it's 1 month duration. It's only 100 patients. Of course, there are some limitations about that, but it's just kind of interesting to go through this and maybe go over it one by one and see how much physical examination can really help. Okay, and then the other really also interesting paper which I actually got a hold on recently. I don't know if you, apart from the neurologist, but any of you guys hear about the physical examination, maybe picking stroke that was actually missed by the initial MRI. Anybody hear about the HINTS exam? So basically, this is a paper that's published by I think it's in the stroke, in 2009. Basically, a neuro-ophthalmologist based on a prior study that suggests a simple bedside test, they're actually very good in detecting stroke in the posterior circulation. So they looked into the patient with 100 patient with acute vestibular syndrome, patient coming with unsteadiness, vertigo-like symptom, nausea, vomiting. We see a lot of that in our ED. And they included, in their inclusion criteria, they really want to make a high prevalence of stroke in their study population. So all the patients should have at least one risk factor for stroke. And they excluded patients who have recurrent vertigo because most likely they have peripheral cause of their dizziness. So for the resident, maybe it's, any patient with dizziness, vertigo-like symptoms, the first question you want to know is this peripheral vertigo, like labyrinthitis, Meniere's disease, or this is actually more serious central vertigo, which is a disease in the cerebellum brainstem, and stroke is one of the differential, of course. And then the neuro-ophthalmologist, right now probably he's a faculty at Hopkins. And then all the patients underwent MRI within 48 hours of admission. And the neuro-ophthalmologist, he did a full neuro exam, but he specifically looked into 3 of the physical findings that I'm going to show you guys. This is the first one. It's called the horizontal head impulse test. So basically, it's you can do it in different ways. You can probably the best way is to ask the patient to focus on one object. Maybe if you examine the patient from the front, maybe just to look at your nose, or if you can just hold your cell phone with the camera on and ask the patient to look at the camera. And then what you do is to quickly tilt the head of the patient right and left, and instructing the patient to keep his eyes on the camera. And then what you look at is whether the patient is able to maintain focusing on the camera or not, or whether they actually need to kind of refixate what they called corrective saccade. So with most of the peripheral vertigo, they actually have an abnormal test, which is reassuring. But if they have a normal test, it actually might indicate a central cause of vertigo, which could be a dangerous sign, as they called it. The other is nystagmus. So what I'm going to show is actually the one you really want to find in your patient, which point towards a peripheral cause of vertigo. It's called Alexander's law. Let's see here. Hopefully it will work. So they're asking the patient now to look straight ahead.
Okay, look over to your left. Stay there. Keep your eye wide open.
So what's the direction of the nystagmus in this patient?
Try not to blink at all. Try not to blink. Okay.
Right or left?
To your left. Stay there. Keep your eye wide open. Keep your eye wide open. Wide open.
Right or left? So usually you go with the fast movement, right? So as you see here, it's actually to the left. Now they're asking the patient to look at the right and left to see if the direction of the nystagmus will change. If it changes, this is a dangerous sign. And if it doesn't, this is a reassuring sign, which is called Alexander's law.
Now look over to your right.
Now they're looking to the right. And it's less prominent when they look at the opposite direction of the nystagmus.
Left for a few seconds.
And when they fixate, actually the nystagmus gets better. As you see here. So this is the left side nystagmus in a patient who had actually many years disease. So this is reassuring because it doesn't imply central cause. And then the third one is basically the alternate cover test. As you see in the first image here, oops. This one here, the patient, when you ask the patient to fixate on a front object, they have normal alignment. And when you cover one eye, you see the eye lobe is going upwards. And then when you move the cover to the other eye, the patient refixates. And then this is called vertical ocular misalignment. And this is also could be a dangerous sign indicating central pathology. So these are the three physical signs that he really wanted to test compared to the MRI. So, as expected, because a lot of patients, they have risk for stroke, and they ruled out most of the labyrinthitis and many-year disease patients. They have a lot of patients with central causes. So most of them, 69% of the 100 patients, they actually have ischemic stroke, and few of them had hemorrhagic stroke and other like demyelinating disease. And one, I think, was a side effect of carbamazepine. And then what happened is actually the what he called a dangerous bedside exam, or the HINTS exam. He actually was able to detect all these patients with a sensitivity of 100%. And of course, the specificity is 96 because it can't really tell you what's the lesion. It tells you there's something wrong with the midbrain or the cerebellum, but it cannot differentiate. MRI can. So that's why the specificity of the MRI is 100%. But the MRI actually missed 8 cases of the patient who were identified by the dangerous test. And how did they know? Of course, because there's a concern that they still have a stroke. They repeated the MRI within 48 hours, and sure enough, these patients, they did have a stroke, which was missed at least by the radiologist who read the images. So if you calculate the likelihood ratio of that test is basically close to 0, which is really the best negative likelihood ratio you want to ever have in any test. And then the initial MRI was a little bit less, but of course it's really extremely good. So for those who are kind of not familiar with the numbers, it's just, the likelihood ratio negative of 0.12 is the likelihood ratio negative for the D-dimer test that we all love to do in someone who has a low risk factor for PE to rule out PE. So it's a really good test to rule out disease. So basically, of course, again, limited number of patients, high prevalence of stroke, and how much we can, apply the external validity of this to our daily practice is probably challenging, but still I think it's very interesting. I wasn't aware of this until I started reading about physical examination importance. All right, so in case you're worried about the cases that were missed by the MRI, these are the diagnoses. All right, then the last topic is basically, I'm going to touch base on is evidence base and how much literature we have about the physical examination being really useful in terms of sensitivity, specificity, and all this. We all, look at the drugs, medications, investigations, how sensitive they are, how, specific they are, but we kind of maybe lagging behind in terms of the usefulness of not only the physical exam, but even the history. I realized that they tested a lot of the questions that we asked our patients and whether we should really ask these questions or not and how useful these questions are. Probably the most useful one I personally found, probably you guys have other resources, is the initiative done by JAMA, which is the Rational Clinical Examination. They really did a very good job doing a lot of systematic review of many of the common physical examination findings in different systems. They looked into the same thing that we look at for any other test, in accuracy, sensitivity, specificity, likelihood ratios, and all this. And they usually start with a case scenario that kind of help you see if that's really relevant to your practice or not. So basically, they look into almost all the system. They look into the cardiovascular system, a lot of the common problems that we face in the respiratory system, the abdomen, the neurological exam, and the musculoskeletal exam, and even something like clubbing and volume assessment of volume status. So it's really useful. I think if you depending on your practice, if you have any physical finding or examination that you usually do a lot of time, maybe you need to look it up to see how useful it is. And for me as a hospitalist, one of the things that I came across is my patient is having a murmur. It's very common. The resident is telling me, we have this systolic murmur. Sometimes it's relevant to pursue this. Other times it's not really relevant. The patient is having other issues going on, but we have to address it anyway since we picked it up, right? So, in this case, this is actually one of the cases that was published in their initiative. We have a 64-year-old gentleman who had a fall, ground level fall, and he was prepared for surgery, and for some reason, someone picked systolic murmur. Probably not the orthopedic surgeon, but probably the anesthetist. But anyways, they called you because they want to evaluate the patient before surgery. The orthopedic surgeon specifically told you a couple of months ago, he actually had a case where his patient had a post-op MI because of aortic stenosis. So he wanted to make sure that the murmur is actually not from aortic stenosis. That's what's his specific question to you. So you do your physical examination, the patient is basically asymptomatic. He doesn't have, it's just the pain with the fracture, I guess. But, there's the volume, the pulse volume were normal. He had the systolic murmur in the left parasternal area. There's no radiation. The patient had normal S1, no S4. Basically, all your findings were normal. So the question is, what would you do? Would you just go ahead and order an echo? Would you say probably you wouldn't need to, the patient is it's Friday, they're planning to do surgery now. It's going to be the weekend. It's going to be delayed. When you would be your recommendation to go ahead and do the surgery or do an echo first? How many would vote for an echo? Because we're talking about physical exam? So, what's the evidence behind your findings? If you want to go and see how much you trust these findings. Of course, the first thing is how much you trust your own findings, how much you really feel a patient has a normal volume or a normal S1 and S2. That's another topic. But it's a little bit not very clear, but I'm going to show you what I didn't want to say. It's basically they're trying to help you go over the usefulness of these specific findings, for example, in aortic stenosis. So, for example, when they did the systemic review of patient who was having aortic stenosis with the reference being the echo or the cath lab, if you look at the finding of reduced carotid volume, which is a common finding in aortic stenosis, what if my patient doesn't have reduced volume? How does this make less likely to have aortic stenosis? It's actually pretty good. So the negative likelihood ratio is 0.3, which is anything below 0.5 or 6, probably a good test. Again, if you look at your other finding, which is normal S2, patient with aortic stenosis usually have a reduced S2. If your patient has a normal S2, how much this will make aortic stenosis less likely? And again, it's 0.3 to 0.4 in the study they looked at. Radiation, which is kind of surprising. I mean, this one is kind of easy, right? I mean, a lot of us were able to see if the murmur is really having any radiation or not. And the negative likelihood ratio is 0.1, which is close to the D-dimer test I mentioned to you guys. And then, probably not really easily picked by many of us is the character of the murmur, and actually its usefulness. The negative likelihood ratio is 0.3 to 0.1, which is also excellent. And if you're wondering, well, I'm not a cardiologist, I don't know, really, I should trust my finding or not. They actually looked at that and they examined how accurate the physical examination between internists and cardiologists for the common cardiovascular diseases, common murmurs, and it wasn't found to be statistically different. Of course, it's statistically different and in rare cases like rare congenital heart disease or like left ventricular hypertrophy. So don't underestimate your physical examination skills. Another quick case is, and another common problem me as a hospitalist face all the time, is a patient with hyponatremia or a patient who had low blood pressure and whether they are volume depleted or they're euvolemic. It's usually easy to figure out that the patient is hypervolemic, but usually difficult in the other way. So what do you think is probably most useful in the bedside exam? Now, we don't have really a useful surrogate here, right? There's no test or like CT or MRI that really tells you a lot about volume status per se. So in the studies they looked at, the reference was kind of the serum osmolarity and the BUN, just to together with the physical history. So you really have to rely a lot on your clinical judgment here. So do you think the postural dizziness is most helpful? Just the patient telling you he's dizzy because he stand up during the postural hypotension exam, or do you think the postural hypotension is actually more important, meaning decreasing systolic pressure by more than 20? Do you think the postural tachycardia, which is increase of the heart rate by more than 30, or the finding of dry mucous membrane and tongue, which we look at all the time, or the capillary refill, which is a little bit different between the women and men. Usually it's more than, if it's delayed more than 2 seconds in men, it's significant, or 3 seconds in females is significant. Or the skin turgor, or the sunken eyes. Probably the last two is more common with pediatrics. And actually, a lot of the volume status evaluation was done in pediatric population. But still there's a lot of data on the adults too. So what do you think is probably most useful? Which one you probably try to rely more on? If your patient, you're assuming they have like 500 blood loss or fluid. Okay. Any other votes? He said the tachycardia. Sunken eyes. Okay. So basically, all of them are not that helpful when it comes to evaluating patients with mild to moderate hypovolemia. But you're right in terms of the tachycardia when it comes to severe volume loss, together with the severe postural dizziness. These are the two that in the literature they found most useful if you really want to rely on the physical examination. The dry mucous membrane probably come next, but this is number one. And again, it's only done for those who are suspecting a large blood loss. And unfortunately, most of these studies are actually done in healthy patients. So again, as most of the studies, there's some limitations about applying this to the common practice, but at least it gives you an idea. And then for the mucous membrane, the likelihood ratio is 2, which is fair, but not really the number you're looking at. And the negative likelihood ratio is 0.3 to 0.6, which is also kind of good. So probably these are the two that you want to look at. So it's not always the physical examination is, the answer. Sometimes it's still not that reliable, and you probably need to look at something else. So, it's not only the rational clinical examination is what we have for the evidence base. Actually, I was surprised myself when I started looking at that. There's actually a lot of data. There's a lot of resources for the importance of physical examination and how we can trust it in our daily practice. So this book is actually very good because it always tells you what the likelihood ratios for the particular physical examination in all of the systems, and there's many others too. All right, so to wrap it up, I'm gonna just go over like 3 cases. That's just for I think they're cool. I saw this during my practice here in the, since I started about 1.5 years ago. So this patient I saw in the community regional medical center, basically I was in the neuro hospital service. The patient was admitted to my service after about a day of ICU stay after he had a brain tumor resection. What it looked like glioblastoma multiforme, a kind of bad brain tumor, as you know. So he's in the mid-50s. He had a history of hypertension, and he had a history of vasculitis. That's always mentioned in the chart. But I really, there wasn't any clue about exactly what was the cause of his vasculitis. And he had actually had a severe peripheral vascular disease, and he had bilateral PKAs. So I had him next time after being downgraded from the ICU. He's doing fine until the nurse called me that the patient is having some pain and probably some mild swelling in one of his arms. And the pain was a major issue. They said some swelling, but he wasn't that swollen anyways. He's kind of obese. So I went to evaluate him. You know, of course, common things come first. So I thought about maybe he had just infiltrated, line, tried to look for cellulitis. Nothing was there. The skin it looked just probably dry, but nothing really that led me to diagnose cellulitis on him. Again, DVT is always a concern for this patient with cancer after ICU stay. So I did an ultrasound. Later on, it came back negative. So I wasn't really sure what's going on until I, do my routine exam. Sometimes when I don't know what to do, I just go on, do what I think is a good physical exam. I usually start with the hand. It's just a habit. I just realized that actually the capillary refill is not that good. But actually, when I examined this patient, this is what I found. Okay. The pain was in the left arm. This is second finger. Okay. So, any suggestions? No, his peripheral vascular disease was mostly in the chart related to vasculitis, but I didn't really dig deep at that time, and I asked the patient, he didn't know, but it was bad enough he had amputation actually. So clubbing, okay. You need to go and read about the clubbing in the JAMA. Well, you're probably right, but it's not really that. Right, so there's a delay in probably the thumb and the first and second fingers, right, but not really in the third and fourth. So it's my first time really to notice anything like that. The only thing I could think of at that time is, he downgraded from the ICU, had a major surgery, and probably he had an arterial line on that hand, just for monitoring, because it's very crucial to measure the blood pressure in the neuro ICU. So I wasn't too sure. I called the vascular surgery. We did the Doppler, and they kind of felt the same, that there's actually reduced pulse in that arm. And even the resident, before they fully discussed it with vascular surgeon, they wanted to transfer the patient to higher care, but after they staffed it, I think it was Dr. Yamaguchi in the case, they, given the prognosis and everything, they wanted to kind of just treat it conservatively and see how it goes, and just pain management, water rehydration, and he actually improved in the next 48 hours. So this is one. The second patient is actually a patient in the VA, which is classic VA patient, 70-something, history of hypertension, history of diabetes, history of hyperlipidemia, history of heart failure, history of CBD. He's currently a smoker. He's have home O2 at 2 liters. He's coming with shortness of breath. So it could be everything, right? It could be the CHF, it could be COPD, it could be pulmonary embolism, is he having pneumonia? And the initial evaluation by our team was probably it looked like CHF, and they actually started diureting him and giving him IV Lasix for 24 hours. We saw him next day. The patient was still having subjective shortness of breath. He's still in the nasal cannula, higher than what he used to. So we stayed there a little bit, rethinking what's going on with this guy. And to be honest, he wasn't that overloaded when I saw him next day. I couldn't appreciate any JVD on him. He didn't have a lot of pulmonary edema. But overall, I felt like CHF is less likely. And together with the fact that he's not improving with diuresis, despite the fact that he is making a lot of urine, make me suspicious of that diagnosis. And I noticed this sign on him, and I'm wondering if you can agree with me about it. Let's see. I'm probably going to repeat it because it's not that clear. So I'm looking at his neck. I'm sure it needs to be repeated, right? One more time. So what is this? We're looking at the Adam's apple maybe pulled down with inspiration, right? Maybe I repeat it one more time. There we go. So this is a trachea being pulled down during deep inspiration. What is that called? It's tracheal tuck. So I looked into the usefulness of that in COPD, and it's actually, Letitia suggests if it's absent, it doesn't make a lot of difference, but if it's there, it suggests actually there is a lot of airway limitation, and it correlates fairly well with a forced expiratory volume less than 50%. So, again, it wasn't that this sign only made me make the diagnosis with COPD, of course. He had bilateral wheezes, could be from heart failure too, but it's just the whole picture. But sometimes the physical examination can really make you feel more comfortable about a specific diagnosis more than the other. And then the last case is actually in back here, actually a few weeks ago. It's also about the hypovolemia. So I was covering the neurohospitalist, and the patient had a cervical stenosis. She underwent a CDF, or basically cervical surgery for her symptoms. Next day, she was found to be hypotensive. The nurse called me just to evaluate the patient, and I went there. She had a history of, I think she was 50-something. She had a history of hypertension and heart failure. So there's always a question again, if this is this hypovolemia because she's post-op, or this is heart failure exacerbation. Again, physical examination, she was actually lying flat and wasn't a lot of distress. So that kind of pried me away from the, heart failure per se. But as I said, physical examination is not always helpful. So I decided to maybe do another, what I think could be considered as a surrogate for physical examination. And I truly believe in the future, I think probably this is going to be a very, not really a replacement, but a very good surrogate for the bedside physical examination, which is basically the ultrasound. So I decided to do a bedside ultrasound to look at the inferior vena cava to see if she's really, my impression of her being dry, she's having hypovolemia, probably she just needs some fluid is really, reasonable or not. So this is the one I got. So I'm sure most of you are familiar with this, but this is this is a heart, this is IVC, and you see it's fairly collapses during respiration, right? So probably it's indicate volume loss. And I really, this image really pushed me to kind of give her the fluid, despite the fact that she's having, a history of heart failure. And just mentioning the ultrasound, I think really we got lucky in our division here in the hospital is we get a 1-week trial for the V-scan. So some of you probably have seen it, and I think it's really a very useful tool. I think it's going to be kind of equivalent to the stethoscope that we carry all the time, and especially for cases that we don't have a strong, surrogate test to make the diagnosis with. So, in summary, I think just to emphasize a little bit of the point we talked about. So, physical examination is lagging behind? Probably yes, and this is not something new. And probably we need to kind of do something about it. And I think it's still useful and it's still helpful. And it's actually probably underestimated. And a lot of us, including me, actually didn't know that there's a lot of evidence examining the physical examination finding related to the common diseases that I actually see every day in the hospital here. And then, this evidence base is actually there. We just need to look at it. Whenever, in your practice, you can definitely know what are the common cases that you see. Just go and examine the question that you ask your patient, examine the physical findings that you look at to see which one are more helpful. And as one, they used to say, the eyes only see what the brain knows. I think for me, probably the key is training. If you really want to be good in the physical exam, I think you just need to kind of pay attention to it. That's all. We have the luxury of having all these tests. A lot of time we have the patient whom we know has a systolic murmur with aortic stenosis. It's not really, making any difference in the management at this point, but why don't I go back and examine him really thoroughly, just focusing on the aortic stenosis findings, since now I know he had aortic stenosis, and try to get a feeling of what the bus volume looks like, what the delay in the character of the pulse looks like, what's a normal S2, and a muffled S2 looks like. Just make it a habit. Time, again, is a pressure, and it's a valid concern, but I think if you want to learn it, it's still very cool and very, very nice, and you'll feel very, very good about it. And now I can take the questions. I don't do that to my patient, by the way. So. All right, thank you. Hey. What is that? Oh, thank you. I know.